Welcome to Inflammatory Arthritis and its treatments. My name is Carolyn Wiskin. I'm a clinical pharmacist at Charlton Health in Hamilton, Ontario. This is Module 3, where we will look at holistic and conventional disease-modifying treatments. When we talk about the treatment of inflammatory arthritis, we often use the term treat to target. So what does that mean? Treat to target means that our goal is low disease activity, if not remission. And with that goal in mind, we know that we need to start treatment as soon as possible with what we call disease-modifying anti-rheumatic drugs. So as soon as we identify someone has an autoimmune condition where excess inflammation is being made, the immediate thing is to get them on treatment that is going to modify the course of that disease and stop that inflammation. And then we want to monitor that person every 3 to 6 months until we know that we are at that low disease activity, should we need to switch or change therapies. So quick identifying, getting people on treatment as soon as possible, and ongoing monitoring is how we're going to maintain that low disease or remission state. I'm a pharmacist, but I can tell you that medication is not the whole story. We have to take any therapy in a holistic approach, and inflammatory arthritis is no exception. So when we think about the non-pharmacological means of trying to control disease and prevent flares, we certainly know that time spent in water, what we refer to as hydrotherapy, is extremely beneficial on the joints. And it's also able to give us great mobility, which is also important. There's also a sense of relaxation. So any ability to get in the water, especially a warm water pool, is highly recommended. Then we know that things that promote relaxation and decrease stress, whether that's Tai Chi or yoga, has also shown to decrease flares. It's not a coincidence that at tax time, someone who's an accountant is flaring with their autoimmune disease. And school teachers, when it's time to do report cards, will often be saying, my goodness, my disease is flaring, or someone planning an important event. So when you have deadlines and there's emotional stressors, you do make an inflammatory, I would say, increase because you make more cortisol. And as a result of that cortisol being made in stress, it signals the production of inflammatory chemicals. So there definitely is a link between flares and stress. There's also natural products that we can find quite helpful. You'll see here a little picture of a fish with some capsules, fish oil capsules. And we do know that the natural products that reduce inflammation can also be additive to some of our traditional therapies. We have anti-inflammatories. Many of you are familiar with purchasing those over the counter, as well as steroidal products, and then our disease-modifying treatments. So let's go through some of these and find out a little bit more about them. When it comes to natural products that reduce inflammation, there are several. Here's just a few of them. We want you to be aware that these natural products, although having great impact on lowering inflammation, do not modify the course of disease. So they do not prevent damage and destruction to joints, but certainly can be additive to our other traditional therapies. In the case of omega-3 fish oil, it's important to look at the EPA content on a product. There's commonly EPA and DHA in omega-3 fish oil, and the EPA is what really is the anti-inflammatory ingredient, and you want that to dominate at least a 2-to-1 or 3-to-1 ratio, really, is what you're looking for. And some of them even are as high as a 6-to-1. So the higher the ratio of EPA, the better. Doses of 2,000 to 3,000 milligrams a day are really needed for anti-inflammatory benefit. And make sure that fish oil has been microfiltered to avoid the contaminants that get into the fish that swim in our oceans. You don't want PCBs and mercury in your fish oil, so that's important. Curcumin has been known for years as a great natural anti-inflammatory. People certainly can use it in cooking, but there are certain capsules that have a standardized formulation that are very highly absorbed, and those are ones that are good quality. And MSM is another product that has been used for multiple purposes, but about 1,000 milligrams twice a day is thought to be a good dose for helping to lower inflammation. Non-steroidal anti-inflammatory drugs, or NSAIDs as we call them,
are common over-the-counter purchases that I'm sure you've made. Ibuprofen, naproxen, they both are helpful at lowering inflammation. However, these products, unlike our natural products that we just mentioned, such as omega-3 fish oil, can increase blood pressure and cause fluid retention in people who are vulnerable. They can also irritate the lining of the stomach when you swallow them. This can lead to stomach upset or even ulceration, which can cause bleeding in the stool. And sometimes we need to actually add a stomach protectant because of this increased vulnerability. So you'll often see combinations, especially with our prescription anti-inflammatory products, such as things like Vimovo, Arthritis, where a stomach protectant has been added to an anti-inflammatory. Now, keep in mind, although these may make you feel a little bit more comfortable and less stiff, they are still not disease-modifying treatments. So they may be additive to our traditional therapies, but they certainly don't replace them or prevent joint damage.
There can also be used for topical creams. I often think of these natural products, anti-inflammatories, topical creams, like the icing on the cake, where some of our traditional therapies, which we'll talk about in a minute, are really the cake itself that prevent disease progression, but that some of these other pieces can add a little bit of benefit on top of that. And the creams are one example. If you have a specific joint that's really bothering you, adding a topical cream can be helpful. And they have a combination of them, often traditional anti-inflammatories such as ibuprofen, naproxen, diclofenac is another one, may be in a prescription cream or in lower strengths in an over-the-counter product. We sometimes add to that muscle relaxants because often the muscles around an inflamed joint tense up and that can add to our discomfort. And sometimes just the messaging of pain gets so strong from these joints that using creams that have ingredients that block the nerve transmission of pain can also be helpful. So over the counter, non-prescription, there are options, and in combination, you can have prescription products made as well that are combinations of all three aspects. One of the benefits of the topical cream is that it isn't absorbed throughout the circulation. So it avoids stomach upset, it avoids issues with things like high blood pressure or fluid retention that we might see with some of our swallowed traditional anti-inflammatories. There is a role for steroid treatment, but we normally think about using steroids such as the tablet prednisone at times of flare. You may have had prednisone in small amounts when you were first diagnosed just to get your condition under control. While some of our disease-modifying treatments can take up to 3 months to work, it's often nice to have something that you can use right away and calm down that inflamed joint. But to use a drug like, say, prednisone, a steroid, long-term has too many adverse effects for it to be your regular treatment. And what some of those things could be over long-term use is certainly irritation to the stomach lining, but we can also see changes in bone quality, which increases the risk of fracture. We can see elevations of blood sugar, which can really increase our risk of diabetes in people who are vulnerable. And certainly there's a great increased risk in infection. The tissue doesn't heal as well when you're on prednisone, and you're more likely to pick an infection up. So for those reasons, we really like to keep that use of prednisone for a flare, for really what we call a short-term burst, taper it off, and let our disease-modifying treatments be our mainstay, hoping to avoid the need for prednisone. But there's also a type of steroid that's an injection, and that is very isolated to the joint where it's injected. That's the nice thing about it. It's not absorbed throughout the whole bloodstream. It doesn't cause issues in terms of stomach upset or bone quality, that type of thing. And some joints that maybe are really flared and causing you difficulty, you may get an injection up to every 3 months. Of course, if we're using treatments that control disease and put you into a low state of disease, if not remission, we hope to not use oral, as in prednisone, or these injections at all. But it's nice to have these in our tool chest when we may need them. We have what is known as our traditional disease-modifying treatments. These traditional or conventional treatments are named because we've had them for a long time. In fact, over 30 years ago, I hate to say it, when I started working in rheumatology, we had these therapies. And they were novel to us then. We were excited to have something that wouldn't just lower inflammation, but actually stop the progression of disease and prevent damage to joints. And so these treatments are made synthetically. Carbons, hydrogens, they're put together in a chemistry lab. They're not mimicking natural products made in the body. They're not, as we would refer to as biologic therapies. These are our traditional, what we call synthetic products. And the four main ones are Methyltrexate, Laflunamide, Sulfasalazine, and Hydroxychloroquine. We commonly need to use these in combination because often just one of these therapies is not enough. So I'm going to walk you through them. One of the things I do want to mention is that in people with ankylosing spondylitis, we do use our anti-inflammatory products as mentioned earlier, but we haven't found that this particular family is helpful in preventing disease progression or making much of a difference. So for someone with ankylosing spondylitis, the therapies I've already talked about we may utilize, but we would skip this stage and move on to more advanced therapies if we're not controlling disease, and those will be covered in our next module. But for people with RA, or what we call PSA, psoriatic arthritis, we're now going to be looking at these treatments in a little bit more depth.
Methyltrexate is usually our anchor drug. It's the thing that we often start patients on in order to get good disease control, and it can take about 3 months to fully start working. Methyltrexate comes in both a tablet form or an injectable form. And as mentioned, about 30% of people can achieve low disease activity on methotrexate alone, but because that's not everyone, is why we need to often combine it with other treatments. The MOA, or mode of action we like to say, is that methyltrexate inhibits the production of folic acid, or what we call folate synthesis. And it can also impact these T cells. If you recall from our first module, we talked about T cells in the immune system driving this excess inflammation. And so the thought is if we can kill these T cells off quicker, if we can have a greater cell turnover, maybe we'll get smarter T cells that won't generate this excess inflammation that we don't want. So methyltrexate helps with that. How much do we use? The dosing, anywhere from 10 to 25 milligrams a week. We often start at a low dose and work up, although in some cases people start right at 20 milligrams. And it is a weekly dose. But what's important to know is that if you're swallowing the tablets, once you get above 6 tablets, we really find it's not well absorbed if you're swallowing them all at once. So taking that full daily dose and splitting it with, say, if you're at 8 tablets, 9 tablets, take half of them with your breakfast, take half of them with an evening meal. Food always decreases stomach upset with this medication, but we do find that the best absorption and often more effectiveness comes when we give it as an injection. And that injection would still be given once a week. Very short needle, easy to inject, and would avoid some of the potential stomach upset that people can get. So when we look at these possible adverse effects, we have the rare time, not commonly in the low doses that we're using in inflammatory arthritis. Keep in mind, when we've used methotrexate as one of our cancer treatments, it's in doses of about 1,000 milligrams. Here we're talking, 20 to 25 milligrams most people taking. So we usually don't see changes in scalp hair in these low doses at all, but the odd person may experience that. Some people get what we call a methotrexate sick day. That means they have a bit of a headache, fogginess in their thinking, they're feeling tired, just a general malaise that can happen for a day after they get their dose. Some people are a little bit more prone to what we call oral ulcers, so a bit of breakdown again in the mouth. We commonly don't get that, but in the higher doses, not those used in arthritis, you may see that. Liver toxicity, we refer to as hepatic toxicity. This is something that we do monitor for with methotrexate. In the majority of people, we have no issues, but we do regular blood monitoring just to make sure liver function isn't changing. And yes, nausea, vomiting, loss of appetite, that may happen if your stomach's really sensitive. So again, an injection versus a tablet would make more sense. What we've seen is about 8% more people on this treatment than, say, a placebo, which has no active medication, may need to discontinue it due to adverse effects. So certainly let your rheumatologist know if you are experiencing things that you're having a difficulty tolerating. It is important to be taking a weekly supplement of folic acid or in some cases, people are on something called folinic acid. It's really just the activated form of folic acid. And often people take 1 tablet a week the day after methotrexate, but in some cases, people may be taking it up to 6 days a week, depending on the level of adverse effects they may be experiencing. Folic acid is necessary because it does help reduce the chance of nausea, it does help reduce the chance of abnormal liver function, and also reduce the chance of these oral ulcers. And it's for that reason that we want people to take this folic acid on a regular basis. But if you're having issues with these side effects, again, the dose of folic acid may be increased, or we may need to switch it to folinic acid in case you're one of those people that can't convert folic acid to its active form. When we look at how do we get rid of some of that sick day phenomena, again, not everyone experiences this, but the people who can get that fatigue, headache, poor concentration, etc., there is a clinical pearl I'd like to share with you. Dr. Jack Cush, he is the author of a site and regular news blasts in a program called Room Now. And he had the opportunity to come and speak to us in Ontario at the Ontario Rheumatology Association meeting and shared with us that in his experience, taking 2 teaspoons of dextromethorphan, or as you may know it, DM cough syrup, just a dry cough syrup, twice a day, the day before taking the methyltrexate, the day of taking it, and the day after, significantly blocked the sick day feeling. And it appears there is a receptor, an area that can be triggered in the brain that methotrexate signals. It's not how methotrexate works, and it's not how it helps arthritis, but inadvertently methotrexate signals this area that can cause these side effects. And this DM from this cough syrup blocks that area, preventing these adverse effects. So even though you may not have a dry cough at all, you can certainly purchase with no prescription DM cough syrup and try this, the 2 teaspoons twice a day, and see if it's something that may eliminate or greatly reduce this adverse effect if you're experiencing it. We now move on to Laflunamide. And looking at Laflunamide, we know that it is very comparable to using methotrexate that we use as we just mentioned. So it is another great option. In fact, some people are on methotrexate and Laflunamide together, and in 3 months' time, we can see a great level of remission in many people using this combination. Sometimes when methotrexate isn't tolerated, if you're having some of the side effects we experienced, someone may switch from methotrexate to Laflunamide. So we use these in different ways. It does inhibit something called pyrimidine. Not that you need to worry about that, but that is one of the mechanisms that we think is how it helps us. This is an element in cells that are producing inflammation. And we usually start people at about 10 milligrams a day. And after a week or so, to make sure that their gut is adjusting to it, we move up to 20 milligrams. The last column, you're wondering, what does PK and PD mean? This stands for pharmacokinetics or pharmacodynamics. It basically is how medication moves through the system and how it's eliminated and processed. And the odd thing with this Laflunamide is in some cases, even once you stop the treatment, it can linger in the body for up to 2 years. So as a result of that, and this being a drug as methotrexate we would never use in someone who is family planning or who is expecting, we sort of avoid this one altogether in women of childbearing age, because we know that if you thought, hey, I've stopped this, and then family planning occurs after, this drug can linger a long time. So certainly not something we would use in a woman in that situation. Laflunamide can have, but not commonly, some hair loss associated with it. That is reversible when you stop treatment, same as it would be with methotrexate. We have a low incidence of rash, but some people could experience that. The main thing that would make people not tolerate this is nausea, vomiting, or diarrhea. And that's why we start with that low dose of 10 milligrams and gradually work up. But there are many people who tolerate this medication very well. About 10% more people on this versus placebo did have to discontinue due to adverse effects, but of course the majority of people were able to tolerate it. Next, we have hydroxychloroquine. Hydroxychloroquine is probably what we say the least toxic. What we really mean by that is when we combined it to placebo, there was about the same level of adverse effects. It is very well tolerated. We're not quite sure how it works. It is chloroquine that we used for malaria treatment that coincidentally, we found that people who used the chloroquine also had a great improvement in their arthritis. So these malaria patients who had arthritis improved. And so this is really a derivative of that, that we have found to work very well. We think it reduces two specific inflammatory substances and also interleukin 1 and 2, and may also decrease other things you've heard of, such as interferons and prostaglandins. So a variety of inflammatory chemicals can be lowered by this product. We often start people with a dosing that is based on their weight. 5 milligrams of drug per kilogram of body weight, we average out daily. So some people could take one tablet twice a day, or take one twice a day one day and one once a day another, really depending on where that weight comes. And we do know this medication is processed through the kidneys. One of the things when we look at in regards to adverse effects is that we do like to have regular eye exams done, because in the odd person there can be some changes in the retina, and as a result of that we want to keep that dose at that 5 milligram per kilogram. That's to prevent problems with the eyes, but also have eye exams done, and you will be referred to that as a baseline and then follow up periodically while you're on this treatment. Rarely is it an issue. It's really just an insurance that you have that done. It's not common to get headache or dizziness, but yes, the odd person has reported that, as they have with rash. And nausea or vomiting, not common, but I will tell you that when the generic product came on the market, this seemed to increase. And some people have done well by staying with the brand name product. There certainly are cards you can ask your pharmacist for that help to special billing cards that help pay the difference between brand and generic. And for some people, that does make a difference with lowering stomach upset. There was no difference, as mentioned, between placebo and this treatment in terms of level of overall adverse events. And then the last one, sulfasalazine. So sulfasalazine, geez, this has been around for quite some time. We've used it for various conditions. It's composed of really two things. One is called sulfapyridine, and the other one you may have heard of, 5-amino-ASA, as we call it. And so this combination has had impact on reducing inflammation and also reducing the immune system drive to make inflammation. We're not exactly sure of its mechanism. It can be effective as early as 4 weeks, but just like all our treatments, we need to wait a full 3 months before we can truly evaluate, are they going to do what we need? And we do start with low doses and work up. And again, that's just to make it more tolerable to the to the gut as the stomach does adjust to it. And this is something we eliminate through our kidneys. So headache and dizziness is possible, rash is possible, but we do say that the stomach is the thing that, if it's going to bother you, is really the one that has that impact. And that's why we start with low doses and work up. We will also do blood work in this case to monitor liver function, red blood cells, white blood cells, all the things that we also monitor for Methyltrexate and Laflunamide. And withdrawals due to adverse events were higher with sulfasalazine due to these stomach upset events than placebo.